welcome to the podium Dr. Connor O'Brien. Dr. O'Brien is a critical care cardiology specialist at University of California, San Francisco. He's going to talk about RV strain and acute pulmonary embolism. Do all parameters weigh equally?
Thank you very much for having me, Dr. Jaman. This is my first Houston shock meeting. It's really, the reputation precedes itself. It's been fabulous. So I'm here to speak to you about RV strain and acute PE, and do all parameters weigh equally? And there we go. So I think most of us would agree when we get our patients coming in with acute pulmonary embolism, the high-risk category patients are relatively obvious to us, right? They're hypotensive, lactate's high. They get our full attention. All hands on deck. You're trying to get the metrics to go in the right direction. And where I really wanted to focus this topic is more on intermediate high-risk PE and how we use imaging, whether or not we could do things differently to identify patients whose outcome we could modify. And on the right here are echoes from two patients who came to our ICU, both of whom were normotensive, as you can see on their echo, and both had a cardiac arrest. One ended up requiring ECMO support. Both fortunately survived, but they came in with normal lactates and normal tension, and making it really difficult to understand how quickly we should be escalating. So first, we should look at a little bit of the RV anatomy to understand what puts us at risk for decompensation that's unique to the RV. It's a thin-walled structure, doesn't like acute loading. There are two muscle layers, one's perpendicular and one's parallel, and it doesn't allow for acute distension to maintaining RV function and output. Also, the LV contributes about 20 to 40% of your stroke volume. So as you start to underfill that LV, that loss of septal contraction can be really significant for systemic perfusion. And we have many tools for identifying RV strain, and especially like biochemical tools coming out of the ER, but when they come to us, I find that not particularly helpful. While it really helps you identify the significant odds ratio in a paper, the minute-to-minute understanding of these patients and really understanding who's going to decompensate in front of you, we don't really tell you that much. Same thing for CT and echo, when you look at some studies of which patients are at risk for decompensation. When RV strain is identified, and you look at the top line of this chart, when both TTE and CT agree there's RV strain, only about 30% of these patients are deteriorating in front of us. Like, clearly not all of our patients need all of our attention and really need this minute-to-minute monitoring, but some do if we want to make a difference. When McConnell sign, similarly when it's present, when we have normotensive shock, it's very good at identifying low cardiac output. But when you don't have normotensive shock and your lactates are normal, it's a coin toss as to whether the absence of McConnell sign is reassuring. There are many shortcomings with RV strain metrics in terms of understanding what is critical ischemia for the RV, what level of troponin should really get your attention. Also, many of our patients have chronic diseases, many comorbid illnesses these days, and looking at chronic states of stress blood volume, chronic hypoxia might be pushing your BNP up, and how these comorbid conditions are impacting your imaging is not totally clear. You have many changes when you have either, whether it's group or precapillary pulmonary hypertension or a more common group 2 pulmonary hypertension postcapillary. You see a loss of longitudinal shortening in the RV as your dominant driver of cardiac output. So now your TAPSE metric, all of a sudden, it's a little bit compromised. You also lose your homeometric response, which is that inotropic response to the RV to acute loading. So these patients, under this chronic strain, may not be able to handle the acute load of a pulmonary embolism. So when we look at the RV death spiral, I know this is always overwhelming. We look at this and you couldn't possibly keep track of all of these metrics and all the ways it can trip you up and lead to a patient decompensating. But there are some in here that I would like to focus on. So looking here, looking at your RV stroke work and your RV cardiac output, this is something we can actively quantify at the bedside and something you get real-time data and you can watch as your interventions are unfolding. Similarly, you can watch the LV. If your interventions are working on the right side, your LV should be delivering or should be receiving more blood and getting more systemic cardiac output. So the velocity time interval, this is one of my personal favorites. If Chris Barnett is ever watching the season roll over and play dead or be dead. But RVOT-VTI is a surrogate for RV stroke volume. And when you when you look at Eugene Yuroditsky at NYU studied this in their all-comers in their pulmonary embolism looking through their echo lab and was able to identify in a relatively small cohort that it was one of the most sensitive indicators of risk for mortality during an admission. And for those of us who don't readily have the statistics available to us, the negative predictive value and positive predictive value for death was quite good, better than most metrics in other studies. Same thing was true for LVOT VTI. Importantly, in this study, the relationships held up when you looked at an intermediate risk population, and in this study, both SPECI and TAPSI were not predictive of death in this cohort. And a lot of that came down to the fact that it was a relatively small cohort, but it's highlighting how sensitive both of these metrics are. When you want to measure RVOT VTI, this is something we teach all our fellows to do. When we're doing our shock assessments, I really push our fellows and residents to get an estimate of stroke volume and all the different comorbid diseases. Obviously, we get very surprised when our stroke volume is a lot lower than we expect when function looks relatively normal. So you get your parasternal long, and you capture your RV inflow-outflow view, and identify your Doppler signal. Drop your pulse wave Doppler right on top of the pulmonary or pulmonic valve, and you get your VTI when you trace your envelope. You can also find some other helpful information here. When you have a notch, you can find a non-compliant pulmonary vasculature. And a lot of time you can see whether it's coming from your LV or you're ejecting into a non-compliant circuit. It's really telling you that this RV is struggling. This RV is seeing resistance that it is about to struggle against. This is another topic that I think is going to get increased attention across all of critical care, but it's mostly been validated within pulmonary hypertension, is the concept of RV-PA coupling. And putting it simply, this is the relationship and when can your RV squeeze against the resistance that it is seeing. And on the right here, you can see classically this is generated from pressure volume loops, but you can see as the RV gets more hypertrophic and dilates, your end systolic elastance gets lower and your pulmonary arterial elastance gets greater. And what you see is as this relationship goes, you can start to find ways to predict pulmonary hypertension. Normal is 0.8 to 1.3. And there's other conditions that you can see, things like the success and survival following a TTVR, as well. If there's improvement in this relationship, you can start to see whether or improved survival. So the echo equivalent of this is using your TAPSI over your pulmonary artery systolic pressure relationship. And within the CICU, this is Dr. Wiley's with us. This was one of his he was the brainchild behind the study, was able to show that across a diversity of diagnoses within the CICU, that this echo parameter was able to predict mortality. And as you look here, many of these conditions are not related directly to the RV. So it's really highlighting that as the RV becomes increasingly involved, you get systemic congestion following that trend in cardiogenic shock, that this is a metric that really can help identify patients who are high risk for decompensation and death. Though Dr. Jasinski, who's also with us, has did a study of this in pulmonary embolism, and the area under the curve here on the right, you can see the black line being TAPSI over pulmonary systolic pressure performed better, is more sensitive than TAPSI or pulmonary systolic pressure for predicting death. And you can see there's a dose-response relationship there on the left. Once you start getting below 0.33, you get a relationship that can really identify patients who are at risk for decompensating in your ICU. Dr. Yuroditsky also did a study on this, and this study was really focused on high-risk patients. So these patients were high-risk intermediate patients, and these patients they looked at whether or not the use of TAPSI, the relationship between TAPSI and PSP predicted low cardiac output. And within the study, you can see here the receiver-operator curve was very favorable, as this being the most sensitive metric for low cardiac output in pulmonary embolism. And again, there's a dose response. So, conclusions, really highlighting that we need new screening tools to identify high-risk patients, and some of this data that's coming out can be something we could deploy readily at the bedside. This may help us to identify these patients that we've all been struggling and probably keep us up at night, this intermediate high-risk group. And the idea that RV or cardiac output RV-PA coupling becomes a dominant part of the physiology that will help us improve outcomes in these patients. All right, and I conclude.
Thank you very much. It's an excellent presentation, and you seem to be a real expert in the right ventricle. So for me, it's a black box, still the black box. And I have one question. I'm surgeon implanting assist devices. And if I see in the echocardiography very good pumping right ventricle and huge not pumping left ventricle. So my prediction is if it's pumping good right now, it will be good after LVD implantation. But this right ventricle pumps 3 liters only. And after implanting of LVD, it will pump 5 liters. How can you predict the behavior of the right ventricle after supporting of the left ventricle with impeller or with durable device?
That is a very good question, and I think I'd be a very rich man if I knew the answer. This I find something that's extremely humbling, and in the era of 5.5s and some of the other devices that we can put in for temporary right-side support, I find that there's nothing quite like proof in the pudding. You put a VAD in, especially coming out of bypass, you have all that redox species. Your RV can be acutely weak, and predicting when you're going to get RV failure after implant of durable VAD is very challenging. I think many of us probably struggle with that. One of the things that we've been doing is putting in a 5.5 and just seeing how patients respond to increase output, something that you can add a dose response to, and put in, see if you can even train that RV, sequentially wean inotropes. And so that's been one of the strategies we've employed. But again, obviously, then it's challenging. You have to put somebody in an ICU bed, and you're going to keep them there for how long are you going to keep them, right? So
we're going to present some of that data from our center that you can pretty much always get away with univentricular support in biventricular failure if left heart failure is the primary disease. And the Impella 5.5 usually doesn't stress the RV like the HeartMate 3 does, because you don't go on bypass. We do it under local without general anesthesia. So only about, I would say, maybe 7% of our patients out of 250 some Impellas 5.5s need to escalate to biventricular support. And there are markers that we published, a rising CVP, a worsening VIS score, decreasing PAPI. And we're going to hopefully work with the cardiogenic shock working group to come up with a scoring system for someone on Impella 5.5 for when to escalate to biventricular support.
And I think we're talking, it's two very kind of different questions in one, right? So one is biventricular versus univentricular support and shock, and two is prediction of RV failure after surgery, after an LVAD. And so there's, as a non-surgeon, there's this black box of when I send someone in and then when they come out, right? So like how much bleeding is in the OR, all of this, right? So I think those are two different populations. I would say, and all of the scores kind of suck, right? Like we, see statistic of 0.6, whatever we do. And I think it's one of the most humbling things to see some terrible looking RVs do pretty well after an LVAD, but with a longer course, right? And so I think there's a lot of things we can't control, but what we can control is not letting them be in shock afterwards. So I think the milieu of shock, the vasodilatory component, everything about it, the hypotension is bad for the RV. So I think what we can control is if it's a post-LVAD, RV support early, even a priori if possible, and just doing everything we can to create a good environment for the RV. And I think the RV is pretty impressively plastic if it's not the primary lesion.
I want to clarify something, Esther. You said something about bleeding in the OR. I don't recall any of that in my...
Only at my prior institution. I know.
We call it,
it's always 250 cc's, right?
diffuse anesthesiological bleeding.
We blame the anesthesiologist, I thought, anyway.
No, I love that.
So you touched a little bit on the acute PE and RV failure. In your experience, when do you use mechanical circulatory support for acute PE management or extraction of thrombolytics or something when you're doing?
Yeah. So I think, in the cases of cardiac arrest, it's relatively straightforward. If you're intermittently getting ROSC, that puts you in a category you're not going to be able to get to a lab. Lytics probably are going to help you recover that RV. I think the sort of area I'd like to more focus is on our patients when we're starting to treat somebody who has intermediate high risk or high risk. If we're pushing lytics off the bat, if we're starting our vasopressors, starting our inotropes, one of the practices we employ is try to really get a sense of what our response is in our cardiac output. So not just with SCVO2s, but really sitting there with an echo probe and say, I'm going to crank up the dobutamine quickly, like maybe 5 or 10, and say, do I double my cardiac output? Do I double my stroke volume? right? So if I'm putting somebody on, do I know that RV has reserve? And when I put somebody on a vasoactive agent and I look and I see I don't get much of a blood pressure response, maybe my VTI doesn't bump, I start to get really worried saying, this RV better be offloaded really, really fast. And then if we're pushing lytics or going in the lab, start really thinking about whether or not they're going to, seeing what response they get to that therapy and really watching in real time. And, it's a little bit arbitrary, but if I start to see somebody really not responding within an hour or two, and especially if their lactate's really not clearing in the first few hours, that's when I'm starting to call the surgeon to put somebody on.
Can I ask a sort of a clarification question in terms of how you manage these patients? Because the data you showed is very impressive, but where does invasive hemodynamics play in your team's management of these patients? Because in our center, like whenever we get a shock call, one of the first things we always ask is, what are the invasive hemodynamics? We rarely talk about echo findings, or we do, but I usually gloss over them because I'm a hemodynamics guy myself.
Yeah, we usually lead with hemodynamics right off the bat. It depends a little bit, obviously. Being in ICU, we have the advantage of usually having a CT scan. So if somebody has something that's truly occlusive, we don't mess around with PA lines. Sometimes if somebody has a really diffuse clot bilaterally, or if there's a question of whether or not they have CTEPH, that's something we've seen a decent amount of, where patients come in and they have these arterial dilations, really to try to get an estimate of understanding what the PVR is, and see whether or not this might actually be fixed. And we lead off with invasive hemodynamics fairly quickly.
Hemodynamics and echo parameters to sort of
Yeah.
make your decision making.
Usually, sometimes somebody's really unstable, or looks like their A line is dropping by 50% up front. Like we're sitting there, like, this person's about to arrest, even if their map looks relatively normal. Sometimes then we're trying to make an argument to go on ECMO. Fortunately, now that we cannulate ourselves, so sometimes we'll just go on if we really look like somebody's going down the tubes. I mean, that's always really hard to convey. But if you're watching, right, somebody's pulsatility is just dropping on you, and say, I don't have half an hour to align, and then make a decision. Like, we just need to go.
Are you using these measurements routinely early on to guide mechanical thrombectomy?
Not necessarily just for thrombectomy. Like a lot of that, or our decisions for thrombectomy is a lot of time driven by stability. Sometimes they're just not stable enough to move around until we have them on ECMO. So, and we're still pretty heavy lytics users up front, just because you can get it so quickly. And a lot of times, if our patients, especially if they're transferring in from somewhere and haven't gotten lytics and have been getting sicker, rather than waiting for be able to get them to a lab, a lot of time we just introduce therapy right up front to see if we can offload that RV and get things to turn around.
Very good. Thank you very much.
Of course. Thank you for having me.
Thank you.